afternoon and welcome to the Medical Commission webinar series. Today we're discussing TelePain and the UWTelePain and Opioid Hotline. Today we're honored to have Dr. David Taubin, Dr. Jacob Gross, Ms. Kara Towle, and Ms. Mackenzie Welsh. Before I turn the webinar over, I would like to take care of a few housekeeping items. We encourage you to ask questions throughout the presentation. So look for the question box on your webinar portal and we'll do our best to address your questions toward the end of the presentation. We hope that you do not have any technical difficulties, but if you do, look for the help button on the webinar portal to get your issue worked out. We are recording this webinar and the on-demand version and the slide deck will be available on our website within the next few days. Please feel free to share these resources with your colleagues. We want our learning events to be as interactive as possible, so please feel free to use our social media platforms to share what you have learned and keep the conversation going. This webinar is accredited for 1 hour of Category 1 CME by the Federation of State Medical Boards. If you are watching this in a group setting, please make sure you register for the webinar and complete the evaluation as an individual to receive your CME credit. A link to the post-webinar evaluation will be emailed to you after the presentation. Please complete this evaluation within the next 2 weeks to receive CME credit. The evaluation link will also be available on the webinar page. This webinar is not funded by any commercial entity. The speaker, course director, and planners at the Federation of State Medical Boards and the Washington Medical Commission have nothing to disclose. Now, with all of that out of the way, I will turn it over to our esteemed panel.
Okay.
Well, thank you, Jimmy, and thank you for joining us today. I'm Dr. David Taubin, and unfortunately, we are having a few technical issues on your end. So I'm invisible and even have a coat and tie on for the occasion. So you can dress me up, but you can't get me on the webinar. But I'm recently the Chief of Division of Pain Medicine at University of Washington. I retired partially and I'm now emeritus professor. I'm an internal medicine specialist and a pain specialist, and I'm happy that our whole team is assembled here. I was involved in the initiation of our UWTelePain program since its onset 10 years ago. So this is our 10-year anniversary, and we also have added the hotline. We'll be discussing today how to apply pain management and opioid prescribing-based telehealth modalities into your clinical practice. We'll delineate specific telehealth attributes that support guideline-compliant care for your challenging patients with chronic pain. We hope also that you'll be able to differentiate the benefits of using the Pain and Opioid Hotline compared with UWTelePain, and also describe the value of Pain Tracker, a tool that you are able to access now at no cost to you, which is a mobile app that both you and your patients can use to help assess their pain. The other panelists today, in the sequence of which they will be speaking, it will be Kara Towle. Kara has 20 years experience in telehealth, a master's degree in nursing, an international educational administration degree, and established the University of California, San Francisco International Medical Services with telehealth programs reaching throughout the globe. She was the founding director of telehealth service at UW, created a rural telehealth network, delivered numerous programs and services, and since 2016, she's been working with the Department of Psychiatry, and since 2020, she's been working with us in the Anesthesia and Pain Medicine Division, and has been board chair of the Northwest Regional Telehealth Services and a founding board member. After her, I will speak a bit. Then Mackenzie Welsh. Dr. Welsh is a clinical pharmacist with specialized training in pain management and palliative care, employed at UW, rotating through inpatient chronic pain services, inpatient palliative care services, and at the Outpatient Center for Pain Relief. She has a BA in Health Sciences at Drake, a pharmacy degree at the University of Iowa, and completed residency training at Scripps Mercy in San Diego, California, and at the University of Washington. So why don't we move to the next slide, please?
Let's see. There we go. Shall I go ahead?
Proceed.
Okay. All right, so I'm on for the next few slides. So thanks for inviting us to join you today. So I'm going to talk about just the telemedicine pieces of this. And as you've seen probably over the last several months for sure, and even before that, there's a lot of terms that are being thrown around, telemedicine, telehealth, digital care, virtual health, things like that. These are often used interchangeably. In my mind, digital health is a more broad term that includes telehealth, and then telemedicine is a subset of telehealth. And there's actually no standard definition for these terms. The definitions of telehealth and telemedicine, digital health, it can vary depending on payer, depends on whether you're looking at federal legislation or individual state legislation. So I borrowed this set of definitions from the National Center for Biotechnology Information. I thought that they sort of hit the mark. So telehealth is the use of a technology-based virtual platform to deliver various aspects of health information, prevention, monitoring, and medical care. And then telemedicine is the practice of medicine via remote electronic interface, including doctor to doctor and patient to doctor. So telemedicine can generally be categorized into 5 different modalities. Real-time interactive consultation, by far the most commonly used modality. It can be provider to patient, such as in a telepsychiatry visit, or a provider to patient with another provider present on the patient side, or it can be just provider to provider without a patient present. In the state of Washington, we just passed a bill, House Bill 1196, that provides payment parity for healthcare via audio only or just telephone. And that is then considered telemedicine now by that legislation in the state of Washington. So I suppose I could add a picture of a telephone call for the next time I do this presentation. Store and forward telemedicine is the asynchronous exchange of an image, such as a photo of a skin lesion or a CT scan, often comes along with clinical information, or it can be a video like an echocardiogram or even an interaction with a patient. The consulting provider reviews and then sends back the recommendation or treatment guidance. Except for teleradiology, this modality was fairly underutilized, largely because it wasn't paid for by CMS except in Hawaii and Alaska. But new legislation, especially in the state of Washington, and new payment models, store and forward is becoming more common. So remote patient monitoring might include what's pictured here, where a patient is measuring healthcare data such as blood pressure or O2 sats, sending that data to a provider who's tracking it over time. Or it can be something like a tele-ICU where doctors and nurses are monitoring patients at a remote site or maybe even at multiple remote sites. RPN reimbursement was fairly limited prior to the pandemic, but it's starting to build more steam as reimbursement has changed during the pandemic. And CMS, by the way, does not consider remote patient monitoring to be a telehealth in terms of billing rules and restrictions. Then we have case-based teleconferencing. This is similar to a tumor board or a case conference over video teleconference, often with multiple sites joining in for discussion, education, such as the TelePain program that Dr. Taubman and Dr. Gross are going to talk about, or the ECHO model, which many of you have heard of. This is a very popular model. It's a little bit easier to set up than a clinical service. It offers education. Sometimes CME is attached to it, and also offers case consultation. Financially sustaining ECHO programs is always a challenge. I don't know any that are truly self-sustaining. Most are funded by grants or through state agencies. mHealth refers specifically to the use of mobile devices to monitor, for example, patients' exercise or heart rate or medication adherence. Some mHealth applications are beginning to integrate with electronic health records. And in my mind, that sort of crosses into the realm of digital health. Let's see. Oop. That turned out kind of funny when it came across. I also just wanted to point out that in addition to the remote patient monitoring that CMS does not consider to be telemedicine, CMS also has communication technology-based services that include virtual check-ins, which are, brief 5 to 10 minute visits or check-ins, and that can be done over phone or video or store and forward. You have e-visits. Those are remote evaluations of pre-recorded data. So in other words, a non-face-to-face, but patient-initiated digital communication over a secure patient portal. And then there's e-consults, which are, again, interprofessional consultations via phone or video or internet, store and forward EMR. So e-consults, provider to provider, e-visits are provider to patient. And even though these services use telehealth technologies like video teleconferencing, CMS doesn't consider these services to be telemedicine services. And as such, they're not subject to all the same restrictions placed on reimbursement for telemedicine, though they do have some of their own restrictions. And they also have a different fee schedule, which is usually lower than what a telemedicine visit would be reimbursed at. So there was a lot of confusion when COVID first hit and people were billing for that instead of telemedicine, wondering why they're getting such low reimbursement. So I put up this slide because historically, in other words, before the COVID pandemic, these were the remote and rural areas that telehealth primarily aimed to serve. People living out in remote and rural areas didn't and still don't have great access to specialty care. It's too difficult and expensive to recruit specialists. Often there isn't enough volume to support a full-time practice. So they rely heavily upon primary care providers who manage a large variety of often medically complex patients, don't always have the training in specialty areas. And these providers often reported feeling pretty isolated from support and resources. So again, before COVID, we typically saw hub and spoke models where larger healthcare systems partnered with smaller systems or hospitals or clinics to provide consultations with local providers about their patients, sometimes to see patients directly when the patient was sitting in that local facility. And sometimes it was just to offer better continuity of care when a patient had to be transferred in or discharged back to the care of the local provider. This model helped patients by improving access to specialty care, saving the time and expensive travel into a place like Seattle or Spokane, and it allowed patients to stay closer to home and to their own support systems. It also supported local providers through consultation and education to support them in practicing at the top of their scope of practice, and by supporting them financially by helping them to keep patients within their own system. And then we saw that telehealth was helping to meet the Quadruple Aim. Lots of studies showed fairly high patient satisfaction with telehealth and telemedicine due to the convenience that it offers, the cost savings, better access to care. And that better care and earlier access to care help to improve the health of populations, as well as helping to lower the per capita cost of care. Telehealth also helped to lower the cost of care by helping to keep patients local when it was appropriate to do so and making referrals into specialty care only when it was really necessary, again, through supporting local providers to care for the patients. Generally speaking, and under normal circumstances when telemedicine wasn't sort of being forced upon us, providers also reported good satisfaction with telehealth. It supported them in providing high quality and appropriate care for their patients, and it provided that collegial support and resources and a community for those practicing in isolated locations. And then when the COVID pandemic hit, it gave us another reason, another answer to the question, why telemedicine? Why do telemedicine? And of course, that was to be able to continue to provide care while reducing exposure and risk associated with the COVID virus. And since then, the practice of telemedicine has really shifted dramatically to that direct-to-consumer client-patient model and sort of bypassing the local providers. So just making the point that, in my opinion, at least going forward, I think we need to be really careful about not bypassing our local providers and to continue to use telemedicine, to continue to support those local providers and the really critical roles that they play in providing healthcare to their communities. And this is just a slide to give you some resources for telemedicine, telehealth practice. There are, I think, 14 different telehealth resource centers across the United States, and we are served by the NRTRC, the Northwest Regional Telehealth Resource Center. And there's also 2 national resource centers, the telehealth technology, I always forget what TTAC stands for anyway, so it's the Resource Center for Technology, Telehealth Technology. And then there's the Center for Connected Health Policy, which is focused on policy, and it has a great resource for watching legislation across different states and at the federal level. And I think that's it for me, and I'll turn it over to Dr. Taubin now.
Yep, thanks, Kara. So we set the basic characteristics of telehealth. so you can understand telehealth, telemedicine, how they work. This is courtesy of the Washington Medical Commission at their website. Just different resources to locate if you need help and assistance on that. A great resource. And being a physician and therefore under the auspices of the Medical Commission, I'm happy to say that I've often used their site and have found it quite helpful. I did want to call out also the pain management resources is another link. And since we're going to be talking about pain, that's another direction that you might find useful by going to this website. Next slide, please. So how does all this fit together? Again, there's all sorts of e-this and e-that. This fits under a rubric of e-health. Both the TelePain program and the hotline fit that because they are live or recorded, in our case live, educational presentations or educational advice to geographically disparate groups of patients or healthcare professionals. So treatments that are recommended, suggestions that we offer are recommended in the context of an educational activity. There's no established treatment relationship. You who are caring for the patient know them best, and they know you best. And in areas of such challenge as chronic pain management and opioids, that's the relationship that we're trying to reinforce. It is not billable per CMS rules, unfortunately. We want to call out that the Washington State, the 1427 opioid rules, which re-identified and relisted all the characteristics of being supported by a consultation at high-dose opioids, complex patients, concerns, et cetera, would count as a consultation. So you're able to list this in your record as you received a consultation, and therefore you're able to continue to provide care for your patients. This is one of the most important things to be able to communicate. You also, of course, because it's supported by the state legislative authority through the healthcare authority to provide a contracted relationship with us, it's free to you. So you can earn CME credits for the TelePain portion, not for the hotline. So those characteristics, I just wanted to clarify as we move forward. Next slide, please. Thanks, Kara. So this is a busy slide just linking TelePain and the hotline. This is actually when we were doing it live, a view, and we hopefully will get back to that again. That's our group in the pictures on the left. The transition of this through the electronic sources have overlapped many things, unfortunately, but you can see guideline adherent care, opiate addiction management are all readily available. So this is an effort to improve primary care competency and immediate access, the quadruple aim that Kara was talking about. Next slide, please. So a quick history of TelePain and hotline in 2007. Long remote history to some of you. Seems like just yesterday to me. We worked with the Medical Commission and the other agencies that are associated with the medical directors, Agency Medical Directors Group, formulated opiate prescribing educational guidelines. At that point, we recognized that there were insufficient numbers of experts who could provide this support. And I was tasked with how do we make this happen in the state to allow people to follow those guidelines. Next click, please. So in 2010, making it even more challenging, you may remember 2876, the rules. Now, these were no longer educational guidelines, but prescribers, particularly for high-dose opioids or challenging patients who are doing poorly, a pain consultation was recommended. Next click. At that point, it was clear we needed to do something. I joined the university at that point and recognized with the wealth of experience and people like Kara Tal and others working with telehealth, we were able to launch this in response to opioid misuse, abuse, and inadequate pain care as the TelePain program. Next click. In 2017, the Washington State Healthcare Authority funds us and the TelePain side and the pain opioid consult hotline for clinicians in response to the continuing opioid crisis. This allowed us to move from philanthropy and grants to a moving forward process. And we've just been refunded again. So we have at least 2 more years and hopefully longer to be able to continue to provide this free service. Next click. We're going to hear from Dr. Gross a bit later about the web-based pain tracking tool that is outcome tracking, and Dr. Gross will speak to its advantages. This is free. It allows you to get access to complicated pain metrics, measurements, more than pain intensity. And this is a new release since the winter of 2020. And we're looking forward, perhaps you or your colleagues would be interested in participating in that as well. Next slide. So the problem with pain care now is that there are, number one, too few providers of multidisciplinary pain care, even in a resource-rich region, even in the city of Seattle, where there's so many providers. To get access to multidisciplinary pain care is difficult. As Kara alluded to, rural and remote communities are out there on their own. Next. And most specialties caring for patients with chronic pain have had limited training. Next click. Transportation challenges for patients to be seen at a site, particularly if they're physically frail, as many patients with chronic pain are, as well as elderly. There's more folks developing more pain issues as they age, and managing complicated pain patients who are older becomes even more difficult, and the ability to provide services without them moving to see the provider is often helpful as well. Next click. Patients with chronic pain have higher risk of depression, anxiety, and post-traumatic stress disorder. This is difficult to manage under the best of circumstances, and a primary care provider often has some basic tools, but when things get complicated for the patient and they're not doing well, the ability to provide that as a multidisciplinary pain component is also very important. Next click. And there's also increased rates of prescribed controlled substances, again, adding further challenge. Next. So just a quick review of the Association of Chronic Pain and Behavioral Health Conditions. If you're not already aware, depression, half the patients, 25%, have anxiety, PTSD, 25%, childhood abuse and traumatic life events, over 50% of patients, lifetime suicide attempts, alcohol use disorder, benzodiazepine and concurrent opioid prescribing. Big problem. This makes managing chronic pain and behavioral health conditions particularly complicated. Next slide. So without going into all the details here, the best evidence to support telehealth is behavioral health. So the very common co-occurring conditions can be managed quite effectively by telehealth. We're demonstrating that in our own clinic at the University of Washington now. It's not quite the same thing of being in the room, but patients who are accustomed to it become more and more at ease if they have the bandwidth, if they have the electronic devices that allow them to participate. Cognitive behavioral therapy is the standard. It's the most commonly used telehealth treatment. There are approaches individual, group, and there's self-directed internet learning sites that are now available via telehealth means. Engagement appears improved if the individual actually meets with the provider rather than just an internet event that they just walk through on their own. It's been comparable in efficacy to in-person treatment. I think that's very important to know. Your patients will have near identical, not quite, but comparable efficacy. Treatment satisfaction by provider and patient, as Kara has mentioned, is extremely high. So in-person versus telehealth for the behavioral health component has quite high satisfaction. And as a result, it appears to increase compliance, reduce no-show or cancellation, so your patients can receive that behavioral health care using a number of telehealth means. And we also know that behavioral health approaches can facilitate reduced opiate use for chronic non-cancer pain. So it's a win-win, win-win-win operation, including telehealth technologies. Next slide, please. Our group, myself, Kara, and others have been able to achieve some validated evidence and a journal report recently that patients with complex pain needs living remotely from pain facilities in low resource settings, we can remove the barriers to multidisciplinary pain management using a telehealth, an e-health approach. And we describe our TelePain program in that, as well as the pharmacy services that we're also making available. This was again in response to COVID, recognizing that these folks certainly do need to continue to receive care. Next slide, please. We also know that coordinated multidisciplinary pain management is the best step. Now, in the fine print, you can see this dates back to 2009. Our colleagues down in OHSU were able to identify that doing pain as a team, not just a group of patients, but as a team of experts sitting side by side, problem solving about the patient's case with or without the patient in the room, demonstrated significant improvement in a variety of outcome measures. And this has been replicated innumerable times. But the ability in a primary care setting to include the primary care provider in with the pain experts, so being in the room where it happens, has made a significant difference. And this represents what our TelePain program is attempting to accomplish. When treatment providers are not co-located physically, you're not in the same room with them, we still need to be able to communicate electronically. Next slide, please. So with this, and again, an electronically dysmorphic presentation of the slides, sorry, Mackenzie. Dr. Welch, let me take it over for you and describe what you're doing and how you're providing this service for everybody.
Yeah, thank you. So now that we have a good overview of what TelePain and telehealth is, we can kind of shift our focus onto the hotline. So the UWPain and Opioid Hotline, it's actually a free service. It's a phone line consultation service for all healthcare providers in Washington State, and was introduced in collaboration with the Healthcare Authority in 2017. This was in response to the opioid epidemic and more than a doubling of opioid overdose deaths between 2010 and 2015, and then also pending further legislation and rulemaking, specifically 1427. So hotline calls are answered during the daytime between 8:30 and 4:30 with a little bit of wiggle room, and excludes kind of weekends and holidays. And these questions are answered by a pharmacist with specialized training in pain and opioid management specifically, also with collaboration and oversight from a pain-trained physician. So you may be thinking, why is a pharmacist kind of answering these calls initially? Well, the pain-trained pharmacist actually offers a unique expertise in medication management and policy, which is the primary focus and primary questions of the hotline calls. There's also kind of continued emphasis on evidence-based medication selection, titrations, tapers, guidelines, and policy. So how the process actually works is you may be seeing a patient, or you may have already seen the patient, and a question comes up about either what to do with their medications, their opioids, and you're kind of stuck. So you would call the hotline. The number is provided. It's 1-844-520-PAIN or 7246. And it'll actually be answered by a triage pharmacist. And they will collect kind of the nature of the call, your name, and then a good contact phone number. And then they send off that information to myself or my colleague, Christina, or another pain-trained pharmacist. And within 24 hours, although most times it's within that same day, we will contact you back and kind of walk through the patient. You can give us patient specifics, like their name, although it's not required. And usually we just ask follow-up questions and then collaborate together about what we would feel like is the most appropriate decision moving forward. And then obviously answering any other questions that you may have. There are times that we provide follow-up information, whether that's guidelines or literature, and usually that's through email. There are certain instances where the pharmacist feels compelled to bring in the pain-trained physician. And so usually that's done at the time of the call, and then the physician will call that provider back and discuss it further. Next slide. Okay, so both UWTelePain and the Pain Hotline programs meet the Washington Medical Commission expert pain consultation requirements, like Dr. Taubin was saying. Although the hotline does not provide any sort of continued education credit. And since inception in July of 2017, the hotline has actually answered over 400 educational consults to primary and specialty care community-based clinicians and pharmacists. And then next slide. So what do these calls typically look like? So more than 2/3 of the callers are MDs, with the other disciplines such as pharmacists or PAs or ARMPs kind of round out about 10% of those other calls. And there are miscellaneous callers listed here, such as MAs. And so really the primary nature of the call is in regards to opioid medications, with the biggest focus being on how do we taper these patients? Maybe they've been at high doses for several years and it's just really challenging to kind of move them along. Or there are safety concerns in which, escalating a taper is appropriate. So just walking providers through that. Uniquely in the last year, the data that we have, we see that buprenorphine, both management of buprenorphine and then perioperative buprenorphine has also kind of started to increase, which makes sense since we're seeing a shift in prescribing patterns. And so that's actually making up almost 25% of our calls. And I imagine as years continue, we might see that continuing to kind of increase until providers are more familiar. Another thing that we continue to track for our calls are, the MED of our patients. Specifically, if providers are calling in to kind of get that expertise or that consultation that's recommended or required by Washington state guidelines. And so we see that, about 15% of patients have an MED greater than 120, but a larger majority are actually have an MED less than that or on buprenorphine or opioid naive. And I did want to preface that although the majority of our calls are, in regards to opioids, we do have, 15% of calls that are unrelated to opioids, whether that's adjunct medications, policy or guidelines, suggestions for alternative therapies. So that is still a question that is being asked and an appropriate question too. Next slide. And with that, I will pass it over to Dr. Gross.
Thanks so much, Dr. Welsh. So I just want to talk a little bit more about what the future directions of TelePain are, and then a little bit more about Pain Tracker. So where do we go from here with regards to TelePain? Certainly continuing to support our community by educating future providers and how to manage complex chronic pain is a primary goal. And in order to do this and facilitate this, we can work with educational institutions. And one of the ways we're doing that currently is by participating with the University of Washington School of Medicine and their RIGHT program, which is the WWAMI Regional Integrated Training Experience. This program pairs students interested in primary care with providers in the community, hopefully a community that they will potentially serve, in order to gain experience and exposure to rural primary care. And so we recently started a program collaboration with them, participating in the TelePain sessions, where they're able to present cases. And in doing so, we actually incorporate not just student participation, but also that of their preceptors and the providers in the community that they work with. So we get a little bit more benefit than only just working with the trainees and with the learners, but also with their preceptors as well. Beyond that, we're hoping to expand our reach beyond the borders of Washington State. So Alaska is sort of next on our list, and reaching out to their primary care providers is also the next step in helping with UWTelePain's expansion. And that continues on the national level with future connections from coast to coast. And that's really facilitated by our website, which has a repository of all of our recorded didactics and videos that can be accessed by anybody around the globe with access to internet. And then along to kind of lead us into our next topic, thanks to the generous support of the Washington State Healthcare Authority, all providers who present at TelePain will have access to Pain Tracker for free. Next slide. So why Pain Tracker? Well, complex, multidimensional, multifaceted pain, the nature of chronic pain really makes monitoring over time a necessity. And Pain Tracker helps with this. Pain Tracker improves communication, aligns the goals of both patients and providers. It supports their treatment and adherence to therapy, and it measures clinical outcomes over time. It improves patient and provider satisfaction, and as I mentioned before, it is free to anyone who presents at a TelePain session, and they have access to Pain Tracker. And then with our new version that's recently come about since 2020, it has adaptive testing that's both shorter and easier to use to reduce the burden to both patient and provider. And there's an example of the TelePain tracker up in the right corner of the slide there. Next slide. So what exactly is Pain Tracker? So as Dr. Talbot mentioned previously, Pain Tracker is a web-based tool designed to assess and graph core patient-recorded outcomes in chronic pain management over time. And then it displays the relationship between treatments for chronic pain and these outcomes in a way that's accessible to both the patient and provider. And then this format can also be used during our TelePain sessions in order to provide panelists who are actively participating in our TelePain sessions with information about the patient in order to provide improved consultation recommendations. Next slide. So what exactly does Pain Tracker capture? So certainly characteristics such as demographics, pain locations and types, as well as intensity and severity are important. But while pain score is certainly a widely used method of tracking treatment success, it's often a lagging indicator of treatment effect. So pain tends to be more complex than just the pain score, and as a result, the outcomes tracked by Pain Tracker are also a little bit more complex. Pain Tracker is able to track outcomes such as the PEG score, which includes pain severity, but also the enjoyment of life, general activity, sleep interference, all things that can impact how a patient interprets their pain. It asks the patient for an important activity that may be a goal to be able to return to or improve upon with therapy. Pain Tracker evaluates for emotional distress. It evaluates for function, as well as medication side effects and patient satisfaction. And then Pain Tracker, beyond outcomes, also evaluates for risks using validated tools such as the Opioid Risk Tool. It evaluates for sleep apnea using the stopping assessment, as well as PTSD and fibromyalgia for the widespread pain that many of our chronic pain patients experience. Next slide. So more on the adaptive testing and Pain Tracker. Certainly capturing the outcomes I mentioned before can seem like a burdensome or cumbersome task for patients and providers. However, with the adaptive testing on Pain Tracker, what we're actually able to do is select for patients who need to fill out further screens. So the PEG and PHQ-4 allow us to screen for patients who are above the 50th percentile and then provide additional evaluations for those that qualify. And some of those include the HUDAS, which assesses for disabilities across psychosocial biological domains, the PHQ-9, which evaluates more in depth for depression and includes suicidality evaluation, GAD-7, which can help for evaluation for anxiety, and PTSD-5. Next slide. Oh, great. And so what do you get when you use Pain Tracker? So Pain Tracker provides reports that you're able to share with your patient. So graphical displays of how these outcomes are measured over time. I often sit down with my patient and go over the Pain Tracker forms with them, and I can print it out and give it to them on their way out the door, or even at the beginning of a visit to kind of reinforce how treatments are going. The graphical representation is particularly useful because it can show patients who may or may not notice the day-to-day change in their pain, how much their pain has improved and changed over time. And I often, when I first walk in the door, thank patients for completing the Pain Tracker and really reinforcing how valuable it is as a tool to both track their pain treatment and the efficacy of their pain treatment over time. And this can be sent, particularly it's sent to the pain provider, but it can also be printed out and given to the patient for their records as well. And next slide. So just to go a little bit more in depth on the UWTelePain, Pain and Opioid Hotline, and Pain Tracker, we've actually made a video that we can play for you now.
Jimmy, I don't know if you can help us so that we can hear.
Okay, let me try and get that display. Oh. I'm going to try it again. Let me know if you can hear it.
Okay. Audio is not coming through, as far as I can tell.
I don't know how to do that, and I apologize.
Well, we can send the link out to folks after
Yes,
this.
it'll all be available.
Okay, well, with enough telehealth challenges today, I think we're going to be able to navigate through them. It's a bit more complicated than we had expected. So why don't we go to the next slide. So the purpose of this video is in part for you to kind of learn about it as an individual who is not only presenting, but we recently made a decision that if you are a provider in the state and understand this process, you don't necessarily need to present a case, but just become a member of our group so we can help explain what you're using. Because this is something that you certainly didn't get in medical school or your residencies, this kind of tracking tool. So this is designed to explain both to providers as well as patients what it is they're enduring when they sit down and answer these questions. The time it takes to do this pain tracker is minutes, and with the adaptive testing we've added, we can expand it to a much more complicated version for those patients who have more complicated management issues in terms of high distress scores, major interference with enjoyment of life, general function, or emotional distress such as depression and anxiety, which are triggered. So these screenshots represent what you would see right out of the video. Apologies that somehow or other our current webinar approach is not effective, but believe me, you can listen to it because I have listened to it. So next slide, and we have a bit more time. So I think, let me ask Kara to advance. Okay, so to wrap it up, some takeaways, and then we'll get to questions if people are able and interested to do that. So telehealth, I hope we demonstrated, has the potential to transform multidisciplinary pain management by removing multiple barriers to accessible care. And let me add, includes you, the care provider, in that management directly. So you know the patient best, the patient knows you best, the care is best delivered, therefore, in the context of the primary care provider. I mentioned earlier on, as an introduction, I was purely a primary care provider for the first half of my career in general internal medicine, and recognized pain as being such an important component of practice, and just bumbled through it because I didn't have sufficient training. And over time, I'm learning the hard way, and committed to maintaining an academic approach to this. Really do believe with high confidence that having the primary care provider in the room when it happens, we had two great cases today, for instance, noon to 1:30, excuse me. This shouldn't be happening, another glitch here, pardon me. So we had a primary care provider absolutely struggling. We were able to work through that with the provider directly, learn what had been tried, what didn't work, and we're really able to give a real in-depth approach to managing that case. We also had a student who presented, and it was a typical presentation in primary care office of what to do with an individual who had gone through severe life trauma, and how you begin to engage them in taking care of that, which would help their opioid use and function as well. Telehealth is especially important for vulnerable patients, particularly if they live remotely from healthcare. The calls come in from all around the state and the region. When treatment providers are not co-located physically, it's optimal providers to consider any of the e-health technology remedies, and the Pain Opioid Hotline and TelePain represent a e-health technology per definitions that Kara so clearly explained, and very hard for us to follow. So UWTelePain, Pain Opioid Hotline, and the Pain Tracker are available, easily accessible, and free for primary care and specialty care clinicians managing complex chronic pain. Hopefully, and evidence supports, this advances the quality of care and improves guideline adherent opioid management. So next and final slide is, thank you. And you have here for access questions about TelePain, it's just telepain at uw.edu. And again, the hotline number that Mackenzie was able to share with you. So we've worked hard at pushing this rock up the hill. It was actually a bumpy road with technical glitches, but we'll work through that. And I do believe we have time, some delays there, but we do have time to answer any number of questions. So we could do it any, Jimmy, how do you, would you like to, what do you recommend we do?
We can do this a couple ways. First off, I just hope everyone will help me with a virtual round of applause, and thanks everyone for helping us with sticking with us through some of these glitches. We do have some questions. You can use the question box in your module if you would like to type in your question. Alternatively, you can use the raise your hand function, and I can unmute you. But while those questions are kind of coming in and those hands are being raised, we do have a question that came in earlier, and it is, how does one join the group to learn how to access the pain tracker system?
Okay, so Jake, you want to take that, or would you like me, since you were speaking on it?
Sure, happy to. One of the easiest ways is if you email the TelePain email that's up there on the screen now. You will actually get in touch with our administrator, Colin, who will be able to email you the access to UWTelePain if you'd like to join the sessions. If you're particularly interested in access to the pain tracker, he will also be able to email you ways to get that going as well.
Let me just highlight and add to that. It may need a walkthrough, and that's why we initially thought it would be best to have people present or at least watch presentations. But we're trying to remove every possible obstacle to getting access. But to understand how to interpret the pain tracker results as effectively as possible and to be able to share them, that's something that we could do online in real time in a meeting format that we have every Wednesday, noon to 1:30, and you'll be able to present the case or even just raise questions about it live about a particular patient case. So we'll make it possible. If you're interested, telepain@uw.edu. Colin will put you in touch with the right set of people. If it's a pure tech question, we'll get our tech crew. A medical question with the medical crew, a pharmacy question with the pharmacy crew. We will put it together and make it available for you. So thanks for the question, and do hope we hear from you.
And we also have a question, does the pain tracker have a way to interface with EHRs like Epic?
Actually, we were working on that. We've been working on it for a number of years. Epic has many barriers to prevent getting into their system. There are technologies available, and this is a national problem. This is just UW. This is Stanford, University of Pittsburgh, University of Florida, the Brigham in Boston. So it's a big challenge, but there is IT solutions available. As it stands now, it is not a direct interaction. What we have done is when people complete it in our clinic, we print it out as a PDF. We give the copy to the patient copy, which is less complicated and doesn't have a lot of technical terms in it. And the original copy that we need as clinicians, we just scan it into Epic, and it's just kept in our media file. It's clumsy. I know it. We all know it. We've been working on a solution. And if we hear more from the community that you'd like it to happen, we'll pass it upstream to the Epic IT lead, who are beginning to recognize that we have to have this interconnection functionality more available. But there is not a direct EHR connection.
And this person is interested in TelePain, but the time doesn't work. Are there any alternatives or recorded sessions?
Every session didactic is recorded. We are very careful that it is HIPAA compliant, and though cases are HIPAA compliant when they're presented, we do not record it just in case there's a slip up, and we have to be certain that there's no identifiers even geographically. So the didactic is available. Just connect to just Google UWTelePain. The file will open. You'll see recorded didactics. You, for instance, can see Dr. Welch's presentation last week on buprenorphine transition from full mu agonists. Very complicated. She did a great job. I applaud you, Mackenzie. It was clear and coherent, and we have the past 2 years of didactics, a wide range of topics from integrative health to cannabis use in pain to PTSD management, interpreting all these values. And so one can just access that and share it. It's part of our budget expectations is that we're providing the service free, so it's free to you to use. The session itself is not yet available to be fully recorded, and that is something is on our to-do list to figure out how to solve medical legal privacy issues that may be involved in that.
So that is
Excellent.
all of the questions I have.
One other response, since we have another minute before it's 5:01 here. If there's a particular time or other issue, connect to TelePain at UW.edu. Colin will then transition it over to us, and we'll see what we can make happen for you. So we're at your service. And our goal, and my personal goal, and the reason I joined the university 12 years ago, was to make this happen. So we really, if you haven't noticed, Kara McKenzie, Jake, they're all in on this program, and I certainly am too. And I want to thank Jimmy and the Medical Commission for inviting us. And I believe in the newsletter, we have a short article that's available as well about how this service works in a general degree. But thank everyone, and to my colleagues, thank you for joining, and most importantly to Jimmy, who struggled through our tech issues valiantly, if not 100%.
Now, thank you so much for coming and presenting all of this information. I'll make sure that your slide deck and the video that we weren't able to get audio for, and all of this information is on our website, and everyone will get an email with those resources in about an hour. So don't worry, we'll make sure you have access to all that information. And please remember to complete the evaluation to receive your CME credit. And I just want to thank our panel again. Thank you so much. Have a wonderful week, and remember to take care of yourselves.
Thank you.
Thanks so much.
Thanks, everybody.
Thank you.
Bye now.